Good morning, class. Welcome to the online session. This is for lung pathology part 2. We're going to touch on 6 slides for today. So I hope you learn something from the slides. Okay, so let's start. So our first slide would be slide 142. This is labeled as acute respiratory distress syndrome or adult respiratory distress syndrome or RDS. Its other name would be acute lung injury. And in our patients, because of the presence of an injury, it will cause hypoxemia. Patients will present with difficulty of breathing and will also have bilateral pulmonary infiltrates. The reason why our patients may have this type of setting would be due to the presence of conditions, okay, such as the presence of sepsis, the presence of pulmonary infections, or the presence of gastric aspirations. So kindly look at the tabulation that you have in the book for the different causes of acute lung injury. But the three that I have told you are the three most common causes. That would be again sepsis, pulmonary infections, and we have gastric aspiration. Okay, so there will also be a combination of predisposing conditions in our patients. What are they that can lead to ALI or acute lung injury? What are they? Shock, oxygen toxicity when we are giving patients oxygen therapy and we give too much of the oxygen. And then we also have sepsis. So shock, oxygen toxicity, and sepsis altogether would cause the acute lung injury. Okay, so the histologic manifestation of acute lung injury would be diffuse alveolar damage, wherein the presence of those conditions would lead to pneumocyte destruction or pneumocyte damage, and this will lead to endothelial activation. And the endothelial activation would lead to the release of mediators. It will lead to extravasation of fluid, vascular leakage. Thus, it will show the accumulation of such hyalinized proteinaceous material that would surround the alveoli and cause the poor aeration. So this would be the alveolar structures. You can see here the spaces, and there would be some sort of decrease in the elastic recoil of the individual alveoli. Okay, and this is due largely to the presence of the hyaline membranes. It would disrupt the air exchange. Thus, patients will manifest with hypoxemia. So again, this would be very, very significant. The moment that you see the presence of hyaline membranes covering the alveoli, then your diagnosis would be acute respiratory distress syndrome. And aside from that, you also would identify the presence of a lot of inflammatory cells, because one of the conditions for this would be the presence of sepsis, okay, or the presence of inflammation. So you can see the presence of a lot of inflammatory cells in the septum or the septate or the interstitium. Okay, so this is acute respiratory distress syndrome or adult respiratory distress syndrome. Next is slide 139. 139 is labeled as pulmonary embolism. Okay. So let us try to look for an embolus. So this is an embolus wherein it is found within the blood vessel. So where is the most common site of origin for this particular embolus? So this is originally a thrombus coming from the deep leg veins. More than 95% of the emboli in the lungs would be coming from the deep leg veins. And this would occur in patients who have the tendency to clot, or those are what we call as thrombophilic persons. And conditions such as cardiac diseases, the presence of a hip surgery or hip fracture, and those with hypercoagulable states are persons who are thrombophilic. So how do you differentiate this one from post-mortem clot? As what we have read in Robbins, one way to differentiate a post-mortem clot from an embolus would be the presence of lines of Zahn. Okay, so you can see the lines of Zahn already. Okay, the dark areas would represent those with red blood cells. The lighter shades, the light pink, would be the fibrin. So you can see the lines of Zahn present. One important feature to differentiate this one from another slide that we have, which is slide 31, and that is acute infarction, is the absence of hemorrhage and necrosis surrounding the obstructed blood vessel. So that is very important. So you can see here the presence of the alveoli. Okay, still they are viable, no hemorrhagic areas, and you only see the presence of this particular emboli. Okay, so this is pulmonary embolism. Okay, slide 31 is acute infarction. So in the lungs, 10% of the emboli would present with infarction. So this would be the blood vessel wall with an embolus. You can see the presence of the lines of Zahn, okay, alternating patterns of dark and light zones. Okay, this would be the blood vessel wall. Okay, and then the surrounding tissue would manifest with those outlines of the alveoli, and that would signify the presence of necrosis. And aside from that, you have the presence of red blood cells, okay, within the alveoli and within the septa. So you have a combination of coagulative necrosis and hemorrhage. So this would signify the presence of an infarct. Okay? So again, 10% of cases of emboli, pulmonary emboli, will result to infarction. Okay. So next, we have slide 29. Okay. So slide 29 is labeled as Goodpasture syndrome. So I know that you have learned something about Goodpasture syndrome when we have taken the diseases of immunity. Okay. So what is Goodpasture syndrome? So it is a condition wherein there would be the presence of antibodies directed against the non-collagenous domain of the alpha 3 chain of collagen type 4. So again, the non-collagenous domain of the alpha 3 chain of collagen type 4. So this would refer to the anti-basement membrane. So it would affect the kidney, it would also affect the lung. We are going to tackle the kidney pathology for Goodpasture syndrome when we reach kidney pathology or renal pathology, and that is more of a crescentic type of glomerulonephritis. In the lung, we are going to deal with the presence of hemorrhage, the presence of inflammation of the interstitium. So we call it, and presence of necrosis. So we call it as the necrotizing hemorrhagic interstitial pneumonitis. So let's try to look at the slide. Okay. So this would be the area, okay, that would be an example of that particular histologic manifestation. So let's try to look into detail. So number one would be the presence of hemorrhage. So you can see the presence of hemorrhage. Number two, the presence of necrosis. Okay, so you can see the presence of marked areas that would. So you can see the presence of these areas that would show partial hemorrhagic features, and then you have presence of interstitial pneumonitis. You can see neutrophils, histiocytes. Okay, these are anthracotic pigments. Okay, so this would be a combination of hemorrhage, necrosis, and inflammation. So hemorrhagic, necrotizing, interstitial pneumonitis. Let's try to go over with the other areas. Okay. So again, you have presence of necrosis, presence of hemorrhage, presence of inflammation. Okay, presence of inflammation. So this is Goodpasture syndrome. Okay. Next is slide 138. So I think this is already a review for you. Slide 138 is labeled as chronic passive congestion of the lung. Okay. So you can see the presence of the alveolar spaces that are filled with hemosiderin-laden macrophages. So what does it signify? When you have chronic passive congestion of the lung, it means that there's heart failure. So type of heart failure, it's left-sided heart failure, although it can also be seen during the course of a right-sided heart failure secondary to a left-sided heart failure. So it would be seen in the setting of a left-sided heart failure. Okay, so these cells are what we call as the hemosiderin-laden macrophages, as exemplified by the presence of the hemosiderin pigments, and they are also called heart failure cells. Okay. So our last slide for today will be slide 137. This is labeled as bronchial asthma. So a bronchial asthma, let's try to look for, yes, here. Okay. So a bronchial asthma is a chronic disorder of the airways that is associated with episodic bronchoconstriction. There would be airway sensitivity mediated by IgE in younger individuals, inflammation of the bronchial walls, as well as increased mucus secretion. So it can be atopic or it can be non-atopic. Atopic, it means that it is allergic, it is mediated by IgE. When it is non-atopic, it is not related to an allergic reaction. It is usually associated with exposure to viral infections or to air pollutants. Okay. So this would also be seen as a type 1 hypersensitivity reaction that is mediated by IgE. So what are the things that we have to look for histologically? Okay, so let us look at the clinical findings that we would appreciate in the patient. Number one is difficulty of breathing. Number two is the presence of wheezing upon auscultation. So let us look at the histologic findings that we see and look at the reasons why these patients would manifest with such condition. Okay, so what we are looking at would be the presence of the bronchus, and then you have the bronchial lumen. So reason for the wheezing would be this one. Okay, so that's the presence of mucus plugging. So the mucus plugging would cause the difficulty of breathing and the wheeziness in our patients. Okay, what are the other conditions that we see? So, what are these? These are bronchial mucus glands. So there would be hyperplasia of the bronchial mucus glands, and that causes the increase in the mucus secretion. Another would be the presence of this bronchial muscles that would be hypertrophied. Okay, so they are hypertrophied. You can see this one. They are hypertrophied, and then they can cause the constriction. There would be the thickening of the basement membrane. Okay, and then we could also look for the presence of these cells, eosinophils. There would be the presence of eosinophilic infiltration within the mucosa and submucosa of the bronchial wall. And this is IgE mediated, and this is associated with allergic reactions. Okay? So those are the things that you have to look for when you are going to check on the slide for asthma. Okay? So those are the slides that we have for today. So I hope that you have enjoyed this session, and we still have one more session on lung pathology. So see you guys, stay safe, and good morning or good night. Thank you.